Recording. All right, we're good to go. Welcome everyone to our webinar for those newly diagnosed with a gynecologic cancer. This is a collaboration between many sites from across the country. I will put the blurb of all of our logos up in just a moment so I can get it going here. Thank you to all of our partners in making this webinar a success and to the guest speakers for sharing their knowledge. Please hold questions until the end or feel free to write them in the chat and we will have plenty of time for a Q&A at the end of the session here. I would like to introduce our first speaker, which is Dr. Elizabeth Michelson. I always forget the Michelson. She believes in a team approach to cancer care, incorporating research, integrative medicine, and state-of-the-art technologies to treat not only the patient's disease, but also support her whole being through cancer treatment and beyond. Dr. Dixon is trained in minimally invasive approaches, including traditional laparoscopy and robotic surgery. She has advanced research training and is committed to continuing research in order to better care for women with cancer. Dr. Dixon earned her medical degree at Loyola Stritch School of Medicine in Illinois. She completed both her residency in obstetrics and gynecology and a fellowship in gynecologic oncology at the University of Minnesota. Welcome, Dr. Dixon.
Thank you, and thank you very much for having me, everybody. Can you hear me okay?
Mm-hmm.
And then did you want me to share my content then?
Yes, please. I don't
you can share. Okay, let's see. I don't want to screw anything up here. Okay. Can you guys see that?
Yep.
Okay. We can get the slideshow going. Okay. All right. So the title of my talk is, so you heard the C word, now what? So words have meaning and we all use words interchangeably. And one of the things that I'll kind of talk about with this talk is making sure that when you are talking with your providers and you're talking with your team, that you understand what's being said, because especially sometimes we who are in it and involved in it every single day don't realize that sometimes the words that we say may make sense to us, but may not make sense to anybody else. So you've heard the word cancer, and it evokes a lot of different emotions to every single person. And those emotions are different. They range vast from sadness to anger to disbelief. And so, but what happens after you hear that word? And the biggest thing that I want to impart on everyone with this diagnosis now is, what happened? Can you guys still see it?
Mm-hmm.
Okay. Is that you're not alone. Is that you do have a structure of people around you, not only friends and family, but also the providers who are here for you, the ones who are helping you navigate through this diagnosis, the support groups such as WOCA that are out there to kind of help navigate this, and other patients who have gone through it before you, who can potentially help you with answering some questions from their own personal experience. Things are not moving. Okay. I'm having trouble because the banner for the video is like right on top of my PowerPoint. So I'm trying to move it so that way I can see the whole thing. Okay, let's see if that works. Okay, so what exactly is cancer? So cancer by definition is your own cells that have changed and decided not to listen to what your body is telling it to do. So instead of staying in one place, your cancer cells have decided to not listen to your body's signals and decide to go other places. That's what's called a metastasis. They change in how their actual DNA or their own structure looks. So they stop listening to the signals that tell them to stop growing, to stop changing how they look, and to stop doing things that they're not supposed to do, like get extra blood vessels for nutrients, get extra things to help them grow. And so because of the fact that cancer by definition is your cells, every single person on this planet's cancer is different than anybody else's, because your genes are different than anybody else's. And so we really have to find then what is going to be your best treatment option for you. And so if there's nothing else that you take away from this little talk, one is making sure that you understand and are having a conversation with your providers, that you understand and you know what's going on. Two, know that you are not alone, that there are other people there to kind of help you navigate through this. And three, that we have to find the right formula or the right treatment options for you. So how do we start doing all this stuff? And really, it's about doing one foot in front of the other. So again, this kind of comes back to that, do we know what's going on? We need to know what stage we are. And by that is where in the body the cells are. That's all stages. It's where in your body it is. Grade is sometimes thrown about as far as a word that's there. And that is a word that kind of looks at how the cells look compared to normal. And then where do we get information about these words? How do we communicate about these things? We need to get information from places who we trust. And so the understanding of what did or what will happen depends on what kind of cancer you may have, where your cancer started. Now, our cancer care throughout the country actually is sort of changing. It used to be really based on where everything started, where was the site of origin. But now with new treatment options, we're actually looking more at how those genes in those cells have changed and whether we have treatment options for each of those gene changes rather than where the cell actually started. So things that used to be just for lung cancer are now being used for things like ovarian cancer and uterine cancer because we're using them for the gene changes, not for where it started. But what we do traditionally for each one of these cancers is different depending on where it started. And we also need to know what options we have. Are there options going to be with surgery? Are there things that we can do if you are a young woman facing these kinds of diagnosis? Are there things that we can do to help save fertility? Are there things that we can do that are chemotherapy? Are there things that we can do with the different drugs that we now have to look at the actual genes that are changed and do a target for those rather than the traditional chemotherapy, which affects all different cells? Can there be more pinpoint therapies with radiation? Is there a possibility of doing anti-hormones for a therapy rather than doing traditional chemotherapy? What are our options? And are any of these options, especially for younger women, ones that we can save your fertility or not? So this is kind of one of those things that usually is very polarizing. But the problem with Google is we get back to the fact that everyone's cancer is different. Google is something that has a lot of varying gross generalizations about things that may not be applicable to you. So it's a place where you can get some information, but a lot of the information hasn't been vetted. A lot of the information may not apply to you. And really the question is, should we bring that information to talking with our providers rather than just looking up at Google and getting the information just from there? So one place that you can get things for or information from people that you trust are those who have been there. And so these are kind of some of the different advices that people who have actually gone through cancer care have given to those who are now seeing that diagnosis for the first time. So being your own advocate, talking to your providers, don't rush into treatment, go and get a second opinion. That's a big thing that sometimes patients don't think that they can have. They don't want people to get upset that they're looking for another opinion. That's actually a good thing. It's a good thing to know that you have options and that there are other people or other providers who may give you a different option. It's never a bad thing to ask, okay, what is somebody else who has expertise looking at my situation and what do they recommend? And hopefully all the recommendations will be the same. But if they're not, then you can kind of decide, okay, is this recommendation one that works better for me or is this one? But it's never a bad idea to get a second opinion. Look at clinical trials. Some places have clinical trials open, some don't. Some have more ability to go to places like MD Anderson or Sloan Kettering or Mayo, where they might have other options that you might not have closer to home. And how can we work together to try and get you those options that may work for you? And why is this happening? Sometimes we don't have that answer. And almost every person who has a cancer diagnosis asks that question, why? And sometimes we don't know. Sometimes we do know, and sometimes it's because of gene changes in your genes that have changed either in a family tree where potentially those gene changes are familial, or is it just what we call sporadic, something that happened in you? Sometimes it's because of an exposure that you had. If patients have had radiation for one thing, sometimes that can cause cancer someplace else. So why, sometimes we do have an answer, sometimes we don't. And we still have to treat the cancer even if we don't have the answer to why. And how can we make it better? This comes back to the making sure that we communicate. The biggest problem with communication is the illusion that it's taken place. We say things as providers, and we think we've communicated, and sometimes we absolutely have not. And so asking those questions, not being afraid to ask those questions, bringing someone with you to appointments. So maybe if you don't feel comfortable asking those questions, you can have somebody else ask those questions for you, write things down. If you don't have somebody who can come with you, you can actually bring your phone or bring a tape recorder and record it, or have somebody call in to the appointment. So you have a second set of ears to hear what's going on, to try and make sure you understand what's happening. And this is the same thing. Basically, make sure that you are heard for sure. We want to hear what's going on with you, because if you do a treatment, for example, say you're in the middle of chemotherapy and you're having a side effect. If I don't know that side effect is happening, I can't help. So making sure what's going on with you is something that we're hearing, so that way we can help you. Because you're not in this alone. This is a joint venture. We are all in this together, trying to make sure we get you the best treatment that's the right treatment for you. One last, I think this is my last slide, almost last slide. One last thing, just to kind of get into some of the different treatment options that we have that help actually help with some of the side effects of the treatment that we do, is making sure that when you are communicating, you're trying to figure out what we can do to help with some of the side effects of treatment. So movement is a big one, and that is a big movement that's going on right now, that actually trying to decrease cortisol levels, so decrease the stress levels and the stress of having cancer care and taking care of cancer, is something that we can actually do with movement. So either yoga or physical fitness or physical therapy, things like that. And so trying to get some of those side effects of treatment helped by doing movement, by doing acupuncture, Reiki therapy, aromatherapy, the different more ancillary treatments that we can do, to do those together with the cancer care rather than separate, actually helps kind of alleviate some of those side effects of the treatment that we have. And hope. That's something that is really hard to kind of grasp, especially at the very beginning of cancer care, is there hope? And can we find that hope? And what is that hope? And talking about it, it's something that we want to talk about, but sometimes we're afraid to. And it's never a bad thing to ask those questions and talk about that with your provider. So I think we're going to do questions at the end, right?
Okay. Yes. Great. Thank you so much, Dr. Dixon. I think the piece on second opinions is so critical, because I think that's a scary place for people to think about and be afraid that what their doctor's perception might be of that. So thank you for touching on that. All right, next is Ruth Ann. Ruth Ann Ornstein is the LMSW Program Manager of Discovery to Cure, Yale University of Medicine, is a trained social worker, works daily with women in all stages of gynecologic cancer journey. She currently leads various peer support groups, the Woman to Woman program at Yale, survivorship events, educational programming, fundraising, and provides outreach to gynecologic oncology patients at Smeelo Cancer Hospital in New Haven, Connecticut. Ruth Ann is an 11-year ovarian cancer survivor, and upon diagnosis made a commitment and change professionally to give back to the community that helped get her through her initial diagnosis. Ruth Ann is also a wife, mom of two, and a new grandma. Welcome, Ruth Ann.
Thank you, thank you. So we're almost just, Dr. Dixon Michelson, thank you so much. I think our talks go so well together, and I'm gonna go through my process to speak to everybody, but it's so important later on to answer those questions. So I look forward to having everybody put questions together for all of us to answer. I always start off my discussions with that being diagnosed with cancer is like a roller coaster. You're getting on the roller coaster, it's that diagnosis that you've gotten, you're putting your seatbelt on, and sometimes you're going up and sometimes you're going down, and it's okay. Like, it's okay, there's gonna be a way that together with your support, you're gonna get through it. So I always kind of use that, the roller coaster analogy. What I want to everyone to always remember, and some of it the doctor just went through, is remember, use your doctor, use your medical team, whether you have a PA staff, APPs, whatever you have in your team, we all have different setups around the country, that it's okay to ask questions, whether you have a my chart or whatever your system is. Don't be afraid to call, don't be afraid to ask, don't go online. Use your resources that you have, and some people have buddy programs. Use your buddy program if you need. There's always someone there. Remember that the doctor or the medical person is speaking, and they're used to speaking all the time. And sometimes we don't understand a word, or our mind is so set because we're so fearful of the diagnosis or what's happening. Have that person with you. Bring a notebook with you. Get the support, and don't do this alone. You're never alone, and there's always someone. Just bring someone with you. We always tell people, call. I know all the offices are open around the clock. Call if you need, if there's something really going on. Don't wait till the next day. Don't wait 2 days, especially after a chemo infusion or reaction. Make sure you get the right help and don't go online and search for that answer. Communication. This is something, as a social worker and as someone both with cancer and working with patients all the time, is communicating and understanding where you are. Make sure you understand what your diagnosis is, what you need to do, but also talking to your loved ones. I think all of us have different relationships with our loved ones, and there's different ways to talk, and there's so many wonderful resources, whether it's with your children, your grandchildren, your partner, your spouse. Use the people around you and try to communicate the best you can, because that's your support system. And sometimes if those people aren't the right ones, ask for help through your medical team. Do they have the social worker? But communicate. Don't live with all these fears and anxiety by yourself, because as Dr. Michelson shared earlier, we need to de-stress, and we need to take some of that out. And if we sit and just think about it at night, then sometimes we can't get healthier because we're so stuck in our own thoughts. Part of the cancer journey is, depending which treatment you're taking and what's happening, there's a lot of different changes physically in our bodies. And as women, the hair loss is a big issue. Also, depending if when you're put into menopause, did you start gaining weight? Do you have bad skin? Do you have dry skin? Do you see the change? Did you have surgery that you have a vertical scar? Do you have a horizontal scar? Can you not wear that bikini anymore? Do your clothes fit different? These are all real things that we as women go through, or people go through. Use your resources. There's so many amazing programs out there. I know our hospital has a wig program, has a boutique. There's some programs have the look good, feel good. Take advantage of everything you can find, and don't be afraid to ask. Today, we have a group of different organizations throughout the country, and each of us have different programs, and we could all be great resources to help you. Don't be afraid to try the fake eyelashes if that's something that makes you feel better, or try a wig, or don't wear a wig, wear a cap. But make sure there's a lot of different resources. Don't be afraid if you want to try to make yourself look different. This is a great time, if you're someone fun, to put on a purple wig, whatever works. But there are resources out there to help you with that. As discussed before, diet, rest, and exercise, a healthy lifestyle. No one is saying, unless your doctor has specifically told you, don't eat any more ice cream or candy or something. It's everything in moderation. Take care of yourself. During infusion, this is a time that you really need to take care of yourself and be kind to yourself. Be kind to your body. It's okay to not do all the normal things that you do normally during the day, and set small goals. And if you can, get a Tai Chi, get a yoga in, get a relax, get the Calm app. There's a lot of free resources online also. Take advantage, and this is a time to spoil yourself. Really enjoy, and also see what your hospital or if any organizations have available at no charge. I know our hospital does have virtual Tai Chi, and I know some people on this call right now do some of that, and take that chance and appreciate yourself. You want to get better. It's time for healing. It's a tough time, and don't be hard on yourself. Other issues that come up with the cancer diagnosis is finances. And many of the hospitals have patient navigators or social workers that help. It's a real fear. We all have incredible medical teams, but we have to also worry. There's also the worry of finances. Is your chemo covered? Is the medicine you're taking covered? Some women are on what's called a PARP inhibitor. A lot of times there's a very big deductible. That's a very big fear. Ask questions, find out what grants are available, see what other resources there are, but don't let the finances take over your world. Just ask for help. If you need to leave work, talk to the social worker, find out what your hospital provides for you. See, don't do this all yourself. It could be very strenuous and very fearful to take on everything by yourself. Look for help. This is the time that no matter how tough or how brave you are, that's okay to ask for help. And different coping mechanisms. I touched on it earlier. Just practice ways to relax, share your feelings, keep a journal. Many of us have journal programs. And a journal doesn't have to be writing every day. I got up this morning at 8 o'clock. It's about what are you thinking about right now? Maybe getting that thought out of your head. Maybe it's a little cute poem or a song you're thinking of. Just write yourself a note. Sometimes just getting some of those ideas and thoughts out of your head help you to move on. If you are someone who's into religion or some sort of spiritual, look into your chaplains, your priests, your rabbis, or whoever else that you observe with. See if they can help you. Sometimes we're looking for different things to just help us guide through this journey. And for some, if you've taken time off of work or you're retired, maybe volunteer a little when you feel better, or do something that really you enjoy. You love animals, go over and see if you can help out with some animals. Help at a food pantry. Our lives are very stressful to begin with, and it's time during this journey to really take a minute out to take a deep breath and do things that you like to do. And when you're not feeling up to it, say no. It's okay. This is the time you can say no. Many of us like to say yes, yes, yes. But during this journey, please be kind to yourself. And that's the most important thing that we have to remember. And to match with Dr. Michelson and everyone, please, you're never alone in this journey. Not only us at Yale and New Haven, we have resources, but WOCA, Mount Sinai, Teal, all our women that are on here today, all our different organizations, we all have resources for you, and we're all really willing to be there to support you. Doesn't matter where you live, what part of the country you're in. We just want to be there so no one ever feels alone in this journey. And I just want to thank you all for the time, and I'll be available for questions after. Thank you.
Thank you so much, Ruth Ann. You have such a unique perspective as social worker and survivor, so we really appreciate you sharing all of that knowledge with us. All right, I will now hand it over to Blanca, a gynecologic cancer survivor, who is going to share a little bit about her journey with us.
Hi, everybody. My name is Blanca. I am a survivor, and I just celebrated my 20th year of being a survivor. My journey started in 2004. And, it's a long story. I would love to say it, but basically, in a nutshell, I had to fight to find the diagnosis. It was only through my persistence that it was found, passed on from my regular gynecologist to a gastrologist who actually found it. Once she connected me with my oncologist, it was wonderful. My oncologist explained everything to me. I have to be honest and say I never cried. I never, I just soaked it all in. I don't know whether it was shock or just taking it in. But, she told me everything and told me what I would need to have. I had a hysterectomy. And, my post-operative diagnosis was stage 3C ovarian carcinoma. I did go through 6 rounds of chemo. I did lose my hair, which I now laugh about it because I never cried when they told me I had cancer. But when they told me I was going to lose my hair, I boohooed like a baby. And, but we're women, and so that's important to us. I did go through all of my chemo treatments and completed it and was in remission. It did come back 5 years later, but since then, it's been 15 years since my last chemo treatment. I can tell you that most important for me was having that doctor just explain everything to me. The doctors and the nurses letting me ask the same questions every treatment because I would forget or I wanted to make sure I understood. And they were so patient with me, just letting me ask those same questions. also, just letting me rely on my faith for myself, and the women around me that were going through it at the same time. Everyone has their own, as we talked about religion, we really relied on that. And I encourage everyone, whatever source that you use, that's going to be that big foundation that you sort of start on. And, my doctors were great. And they also encouraged me to look for second opinion if I needed to. Just the fact that everything was laid out to me so open, I was very comfortable with this doctor, and I stayed. I didn't feel the need to move to look around because I wanted to take care of it immediately. Like I said, it was 20 years ago. There wasn't that many. I don't want to say there wasn't that many support systems, or maybe I really didn't look into it at the time. I had a 5-year-old and a 7-year-old, and I really just wanted to get back to normal. I just needed to get things done. I needed to start taking my kids back to, soccer and swim. So I did not look for the support system because I had it within my family, within my church, in my neighborhood. So I did have that sort of support system. But as I became more involved in organizations such as Judy's Missions, who I'm involved with right now, I really felt like, wow, I could have really used more support systems to speak to other women going through the same journey at the same time. It could have helped a lot. And so, and not that, by not having it, anything's wrong, but I know that I probably, would have benefited a little more by going through that. But I do absolutely, think that those support groups, all of them are amazing and something to look into. And yeah, that's my story.
Great. Thank you so much. We are getting a few questions right now for Blanca, so I'll just highlight those quickly, and then we can move on to the one about clinical trials. Blanca, how much time did you have to spend in the hospital? Oh, I think I lost audio. I don't know if anybody else could hear.
Can't hear her.
No,
Blanca, we can't hear you.
Sorry.
It
Oh,
was
there.
about 6 days.
Oh, there you go. Can you repeat your answer? I'm sorry, Blanca. I think we missed you.
It was 6 days in the
It is
hospital.
very light.
6 days, you said?
Yes.
And then the other one, did you wear a wig when you lost your hair? And how did you decide which would be best? And how did your kids react to the hair loss?
When I started losing my hair after the second round, it was I was almost relieved because, like I said, after I cried and found out that I was going to lose my hair, it was just sort of like you're just waiting for it to happen. Once it started falling out, it was almost a relief for me because then I thought, okay, I can move on to the next step. I did go somewhere and they just shaved it. The kids were a little scared at first. They were little, 5 and 7, but I think I made it a game. I showed them how my hair is falling out, but I'm still me. This is okay. It's going to grow back. And just like when we get your haircut. And so they were okay tentatively with that. But as time went on, they were fine. I did get fitted for a wig, but I have always, since I was a child, been very hot natured. I'm hot all the time. And so wearing the wig, I immediately started sweating. And I didn't want to wear a scarf because that made me hot too. And so actually what I wore, and I did not want to be just out bald because I was I'm a very vain girl and I just didn't want to be that way. And so I found, they're called newsboy hats, and I had about 5 different colors. And I loved it. It matched with all my outfits, and that was my thing. I loved my hats, and they were just cute. And I made sure to wear big earrings and heavy on the eye makeup, and it just made me feel girly.
Fantastic. All right, another one for Blanca here. Was the treatment for your second diagnosis the same as your initial treatment?
It was not. The first time was carboplatin and Taxol, and the second time was Doxil. I think she felt that this was going to be the best treatment to treat it. And I did not lose my hair the second time. I only had 4 treatments, and the only side effect I had the first time, I really had no side effects other than the hair loss. I was a little tired but I was working full time and I went to work the very next day. The second, during Doxil, I did have some bone pain, but not a lot. Just enough to where I knew it was a little achy. And then, and once I completed treatment, it went away. I have to say, I never really had anything after the after effects.
Wonderful. All right, Dr. Dixon, can you speak a little bit about clinical trials, how to go about finding a good match?
So we can talk about that, but just going back to the hair loss, there actually is, and I'm not sure if everybody knows about this, there are now cold capping devices that are more and more frequently available to help with hair loss. It's not fun from what I've been told. It's kind of a huge undertaking to do it, but more and more providers have this. I don't think a lot of insurances are covering it. Unfortunately, it is out of pocket. But for those who are willing to kind of do the extensive process, these are out there. So if that is something that you're looking into, definitely ask your team if they have it or if they have the resources to tell you where you can get it within your system. So just kind of going over that hair loss is, oh, sure, go ahead.
Okay, so I think I saw on maybe Baycare's social media about you guys got the system in, like the big machine.
Yes, the machine.
So,
yes.
So I guess I always thought cold capping was like something you personally brought with you. You bought it personally and then you brought it with you. Has it switched to like a bigger contraption that now is offered at the hospital?
Well, it's both. So
okay.
It's your own cold caps that have to go with the machine. So it's a huge process. It's a huge undertaking. Okay. I don't want to badmouth it because people do like it, but it's just something.
It definitely has like pluses and negatives about it. Yeah. Did you have something?
Yeah, actually, there's someone in the waiting room also, I think. There's also another company, and I don't know if you have it there, the Penguin one. The Penguin one is much more affordable, but it's much more time consuming. Okay. It's much more time consuming. You can go online to Penguin, and I think it's only a couple $100s versus thousands. And you don't use a machine, but you have to go to infusion with 1 or 2 buddies, and you have to start earlier. And you come, I think they give you 3 different caps and you put them into between the ice and you keep switching them. And it's like, keep rotating them, but that's supposedly very successful. A little more, but it's a lot more time consuming and you can't expect your nurses in infusion to help you in that. But, and I think they're definitely getting better. You know, the cold caps, but everyone says them. I'm sure
I think they're getting better, but it's still, and it's also very variable as how well it works. I have some patients who they did it the entire time. They did all the changes. It was fantastic. They didn't lose any hair, but it was really time consuming during their treatment. I have some patients who did it, and then as soon as they stopped, it all fell out. So it was okay during it, but then it all fell out. And then I have one patient who actually went through it all, and then they went to Mexico to celebrate being done with chemo, and then it all fell out. So it was one of those where it's very variable, but those options are out there. That's the kind of getting back to finding your right plan and your right support system. And if this is something that's important to you, they definitely have those, the availability to do that stuff. So clinical trials. So real quick, because I know that we're kind of coming down to the end. The best place to find all the clinical trials that are out there is clinicaltrials.gov. But that is very, very time consuming and extremely complicated. So the best place to actually start is probably with your nurse navigator or with a support system in your cancer team to say, hey, I'm interested in clinical trials. What would potentially be available for me? Most nurse navigators can then go through all of that and figure out which ones would be available for you. But if you want to do that on your own, or maybe you don't have a nurse navigator, clinicaltrials.gov is the place to kind of start, because you can put in, I have ovarian cancer, I have a recurrent, I have all the kind of specifics that I know in there, and then you can find out which clinical trials you'd potentially be available to be for you. And then you can kind of figure out if you'd be eligible, because the eligibility criteria is where it gets into the nitty gritty. And so that's a little, but you could take that clinical trial and bring it to your provider and say, hey, I looked at this, am I eligible for this? And then they can kind of go through all that to see if you would be eligible. And then I think there's another question about immunotherapy. So immunotherapy, essentially right now, when we talk about chemo, we have this kind of umbrella over basically systemic treatment. So treatment that's going to go over your whole body. That umbrella used to just be what we call now traditional or cytotoxic chemotherapy. It's the drugs that will fit every cell that's trying to rapidly divide or grow. So the old school ones are carboplatin and paclitaxel. Bread and butter, that's what we used to use all the time for basically everything. We started out there because we had the best data for that, and it's been around the longest. But those drugs are supposed to hit everybody, about every cell that you have that's trying to rapidly divide and grow. So it's not specific. Immunotherapy is now trying to look more at specific different targets. So that way it's not hitting every single thing you have that's trying to rapidly grow and divide, but instead hitting the target for whatever it has a drug for. So one that's out there that's called Avastin or bevacizumab, that has an actual target to one of the receptors that causes blood flow and blood vessels to form. It's called VEGF. So that drug is actually looking to trying to block that VEGF receptor so you can't get more blood vessels to the cancer cells. So that's one type of immunotherapy. There's also we call targeted therapies. Those are also ones that are looking at different gene changes. So things like Keytruda, Pembro, PARP inhibitors, those are all looking at actual gene changes, and those are our targets. Not all immunotherapies are targeted therapies and vice versa, but they're both looking to try and hit actual specific things, not blanket chemotherapy like we used to try and do.
All right. There was one comment and then another question for Ruth Ann. One of the comments was to possibly record the sessions with your doctor and then go back and take notes off of that just in case you missed something in the notes, and then you can go back and re-listen to the recording. All right, Ruth Ann, how can patients access nutrition resources and get safe advice about diet and or supplements?
I personally, for us, I recommend you look at see what your hospital has available. Ours has an oncology nutritionist that is available at no extra charge as part of our program. And I would ask that sometimes our medical team doesn't always remember to offer everything, because there's a lot of things like we do 3 massages, there's Reiki, there's other things, but sometimes I think we get into an appointment and there's so much going on. So I would ask, see what you have in the survivorship program, see what they have if you have an integrative medicine program. And if you can't find that, you can always reach out to me. I'd find our information out there to try to help you as well. But there are oncology nutritionists, and I believe most of the hospitals do have programs that can help connect you with it. And sometimes we just have to ask for that.
All right, another one for Dr. Dixon. Can you talk about ice pack for hands and feet during chemo? I assume that's for neuropathy.
So it can be for neuropathy, but also for Doxil. Doxil has, sometimes you get the palm and the sores on your hands and feet. And so sometimes using ice packs can help with that. Sometimes that actually makes it worse. And so people like hot packs. We just have to kind of figure out what's the best one. There have been, especially for neuropathy with foot neuropathy, there have been some studies looking at heat and using kind of the cool setting on a hair dryer to try and help stimulate the nerves. So that's something too that can sometimes help. But with the ice packs on the hands and feet, that's more for kind of the Doxil, because sometimes there can be what's called desquamation. Essentially, the hands kind of start sloughing off, and so that sometimes can help with that.
All right. Can we talk a little bit more about second opinions, about pricing with that? How do you ask for one without making it seem like you don't trust your doctor? And Blanca, did you get a second opinion? So maybe we'll start with Dr. Dixon if you want to elaborate a little bit more on the second opinions, and then Blanca can take over.
So there shouldn't be much cost. Oh, process. Okay, and not prices. I was like, because there shouldn't be much cost, because most of the time when
sorry about that.
They changed it. That will be in your network, so it won't be out of pocket. And most of the larger places like MD Anderson, Mayo, Sloan Kettering, UC Irvine, they all have the ability to do those second opinions, and they wouldn't necessarily cost anything. But as far as the process goes, what usually ends up happening is that we have to put in a second opinion referral into their network. And so, for example, if a patient wanted a second opinion at Mayo, then I would go to the Mayo website. We would put that second opinion in. They would get all the information from us. And then what would happen is they would look at things. And most of the time, in most of the larger institutions, if they look through everything and they say that they don't really have anything to add, they probably won't make you go through a second opinion because it'll be the same stuff. So if they're going to add something, so for example, if they have a clinical trial that maybe we don't have, but they have open for you and you'd be eligible, then they'd go through with that second opinion process and talk to you about that other option. But if someone does end up having the same opinion, then a lot of the times they actually don't keep going with the second opinion. They'll just tell you, we agree with what's planned. And then you wouldn't necessarily have to do that second opinion. And then as far as asking, I would just ask and say, I would like to get a second opinion just to make sure that this is the right thing for me. I don't think any provider would ever say that that's a bad thing or feel like you're not trusting us, because I think it's very reasonable. I mean, if we think about it, you're going to go out and get a car, you look at other options for cars. Why wouldn't you do the same thing with your cancer care rather than just stick with, now, granted, lots of patients don't ask for a second opinion, in which case that's totally fine too. But if you do want to make sure that this is the right plan for you, or maybe it's not a good fit, not everybody's personalities gel with each other. And so if you have somebody that you were sent to and maybe it's not a good fit, find somebody that is a good fit. That's okay. Not everybody is everybody's cup of tea. Like we all have our own personalities and we all gel with different people. And so if it's not the right person for you, that's totally fine. Find somebody that you're going to feel comfortable with.
Mm-hmm. And is that the process you would, someone asked about protocols for long-term survivors. Would that be the same process?
Do you mean like for clinical trials or?
It seems like it's still talking about second opinions. Rachel, is that correct? Oh, it says someone asked about protocols for long-term survivors.
Yeah, I can read you the exact language.
Okay.
Said, I'm a 10-year survivor and can't find info about protocols for longer term. So I think it means more like maintenance, or maybe even if you could talk about in survivorship, how often you need to get monitored, what does that look like, how often you need to get scans, blood work, CA-125s if it's ovarian, that type of thing.
So I think part of the reason probably why she can't find a lot on 10 years is because by 10 years, hooray, and this is a good thing, you don't need us anymore. That's great. Because at this point, usually we look at the 5, 10, and 15 years. Once you get to that, really your risk of cancer coming back has dramatically dropped. And so that's part of the reason why there's not a lot out there at the 10 and 15 years, is because at that point we're back to survivorship as far as going back to the new normal and not necessarily needing a lot of cancer care anymore. So we still say patients should have exams every year, pelvic exams every year, and not necessarily look at cancer recurrence, but more for other things that can happen. Because as we get older as women, we can't see down there. You just can't. Like you can't see down there, you can't feel down there, and nobody's looking down there. So we have patients who are in their 70s and 80s who come in with ulcers or rashes or masses or something going on down there having nothing to do with their original cancer diagnosis, but they can't feel it. So having this, if it's CA-125 is something that's been a marker for you, continuing at that once a year, doing pelvic exams once a year, but pretty much by the 10 and 15 year mark, there's not much else that needs to be done at that point unless there's problems, in which case if things are changing, you're seeing bleeding, you're seeing discharge, you're seeing pelvic pain, things like that, then we absolutely have to do other stuff. But at 10 years, this is a good thing. You don't need cancer care anymore. That's great.
Thank you. Blanca, do you want to touch on did you get a second opinion? I think we skipped over that.
Well, when I I've been trying to find a diagnosis for 8 months. And when I finally was referred to an oncologist, I was at a point where I was just, I don't want to say I was glad, but I know what's wrong now. And my oncologist did actually tell me you know, if you want to get a second opinion, you know, or try these clinical trials, she presented me with those. And, you know, I had been waiting for so long to find something that I did not, I chose not to. And I was very comfortable with my oncologist. I think if I had not been, you know, very comfortable, or, you know, if I had just found out, not really having any kind of symptoms, I think I would have looked out elsewhere, but I just felt comfortable. We clicked very well, and it worked out for me. So yeah, and then as far as um, afterwards, you know, like you know, Liz says, is that, you know, I continued for my first 5 years, every 3 months, and then every 6 months for the blood work. When the 5 year mark, when the cancer came back, we started over. Started at 3 months, and then and by the time I hit technically, you know, 15 years, she released me. She said, you know, at that point I was just once a year, and it was just blood work. For my peace of mind, with my regular doctor, I do ask for a CA 125, and every 2 years I do ask for a CT scan, and they understand why. And but that's where I'm at this point.
All right, we got a couple questions left here. Ruth Ann, what is the difference in roles between an oncology social worker and an oncology patient navigator?
I think different hospitals have different things. So for our hospital, we don't have a patient navigator per se. I run for our hospital, I run a special program that's just out of our gyn-onc. But our oncology social worker helps you with your FMLA paperwork. If you need food stamps, if you have housing issues, if there's anything going on at home, they're there for the support for that piece. And I know some people, the patient navigator helps a little more with extra grants and different things like that. So I'm not a good one on that because we don't have patient navigators. And I don't know if somebody else here has another hospital that does do that. But ours is really, you have an oncology social worker that, and unfortunately in the way of the world, she's not available for everybody, but we try to make sure as many people who need her get her. And then we have our program that's an extra support for our staff, our people. But our oncology social worker does do your grants and does help your paperwork and make sure that your day-to-day stuff is okay. And then she redirects you to a private therapist if you need as well.
And
Dr.
we have
Dixon,
nurse
is that kind of how it
navigators.
works? Yeah, there you go.
Well, we actually have nurse navigators more than we have social workers. So the social worker, as Ruth Ann said, is very spread thin. There's not enough social workers, unfortunately, for all the different places in the hospital. So we have to do the majority of that stuff. And then social workers, if there's stuff that the nurse navigators can't do. So I think it's just a semantics thing as far as what they're called, but they basically do very similar jobs, just depending on whether they're split up. But that's definitely a resource person for all that type of stuff.
Let's see here. Both to Ruth Ann and Blanca, what do you wish you would have known more? What do you two survivors wish they would have known when they were newly diagnosed?
Blanca, you go
What's
first.
something you knew?
Wasn't
We
aware
can't hear you.
of, I was really young, and so I really wasn't aware of many support groups. Like I said, I mean, it was fine. I managed great with my family, my church, my neighborhood, but I really feel like support groups would have really guided me a lot better, because you talk to people going in exactly in that same journey with you. And so probably that, you know, like I said, I was pretty young, not really knowing what else to do. I just needed to get better because I needed to get to my kids.
And I guess for me, it was accepting help when I needed it. I was very independent. I had a 14, 17-year-old. I had to do things. I was working full time, and people offered, whether it was to bring a meal over or to keep, I pushed everybody away. I think I was so sure that I could do it myself. And over time, I realized that sometimes it's okay. It's not a sign of weakness to accept some help from others. And that's it's your community, and they want to be able to do something back. And you can, and as a patient, as a thriver, you can actually ask what you want to sometimes. It's okay to set limits. And I could say that my last surgery, we had a job chart, and people could sign up for morning or afternoon shift. And their shift was, I clearly wrote what I wanted. I wanted someone to come over and walk with me for half an hour or 15 minutes to take a walk and give my family a little break. They only could stay 45 minutes to an hour. And I didn't want them all day, but I really said it, and it was really helpful after my last surgery to have that company and be able to know that I could get out and not put all the burden on my family.
All right, looks like we've got 2 last questions here for Dr. Dixon. Who should get genetic testing and when?
So for ovarian cancer, all should get genetic testing. When is kind of dependent on, one, when you're ready, and 2, where you're at in the process. But everyone should get genetic testing. And actually now they're making the same recommendations for endometrial cancer as well. It's a little bit newer of a recommendation, but they are starting to say that too. So I think that honestly, most patients with a cancer diagnosis by in the next 3 to 5 years probably will say get genetic testing. The reason for that is because there are so many of these newer targeted therapies, ones that are actually looking at gene changes, that if you have a gene change, you're going to want to know about it. So that way you have the potential to use one of these drugs. So I think that's the reason, but it used to be you would only get it if there was a family history. Then it was anyone with ovarian cancer should have it. And then now they're actually saying the same thing with endometrial.
All right, and then talking about clinical trials and when to join one during your journey, does it matter when or when not to?
So I think a lot of that too is what the clinical trial is, because there are some for upfront, meaning that the first line of chemotherapy or at diagnosis. There are some for recurrence. There are some where you will only be eligible if you have X, Y, and Z treatments beforehand. So it really depends on the clinical trial. But if you're interested in them, especially up front, just finding out which ones you're eligible for, that is definitely something that you can get started with either a cancer navigator or, like I said, going to that clinicaltrials.gov and then finding out ones that might be of interest to you and then bringing them to your provider to take a look at. But when to is going to be really dependent on what the trial is.
Thank you. There was one other about Dr. Dixon's slides. I will send an email out tomorrow with a copy of the webinar recording and then both slides from Ruth Ann and Dr. Dixon. So all of that will be sent out tomorrow. We have 1 minute left and I want to use it to do a plug for community-based organizations. We talked a lot about hospital care, what the services the hospital offer. I'm the executive director of a local nonprofit for Wisconsin that helps all gyn cancer patients throughout the state. So most states have something like that that's a nonprofit based away from the hospital, but we work directly with the hospitals. We have our own mentorship programs. We have our own financial support, so we'll help you pay your bills throughout treatment. We have support groups for newly diagnosed individuals as well as young survivors, those farther along in the journey. So a whole different set of resources from the hospital. So you can essentially double dip on the services that you're available to receive. If you want to know if your community has one, I will send the email tomorrow so you can just reply directly to me and I'll look into finding one close to you that would be able to help. But it's definitely an added resource to the services that the hospital offers. We kind of aid in the patient navigator side of things for those newly diagnosed or anyone on the journey itself. Looks like we're perfect timing here. So does anyone have any last minute questions? Otherwise, thank you all so much for joining us. I will send the email out tomorrow and you can always reply to that with questions and we can get those answered as well. Ruth Ann, Rachel, anything else?
No, thank you for all our speakers and for all of you who joined us this evening. And we hope it was informative.
Mm-hmm.
Thanks, everybody. Thanks for
Thank
having
you.
us. And if you have
Great.
any questions, actually know, and then I can also answer any other questions that you may have.
Definitely. Thank you so much, Dr. Dixon, Ruth Ann, Blanca. We appreciate you joining us this evening.
Thank you.
Thank you.
Thank you.
Thank you, guys. Thank you.